Good morning, everybody. It is really an exciting day. And it's not just a simple statement. I'm traveling around the world, attending meetings every second week or so. It is the first meeting in months where I see a multidisciplinary audience. The first one. So congratulations for that. Why? Because I truly believe, and I learned a very nice, I think, quote today. Critical thinking you cannot teach. You need to create diverse environments where it happens. I really love that quote because I really had this abstract thing in mind. I said, how do we really bring critical thinking into the people? I was thinking about teaching. I'm teaching at university, but that opened my mind. Truly enabling these kind of environments will do the trick in AI. So again, second, congratulations. So I'm at Roche, and I'm grateful that my predecessor speaker here actually brought the aspect of creating trust. I think he showed you that we take it really seriously when it comes to implementing AI, both in the company, but also in our products, because I'm not going to cover that part. I'm going to cover from a more medical angle, basically, what we're doing. And having said that, I woke up a couple of days ago to this statement here, if AI can diagnose patients, what are doctors for? I felt first, I made it on time. I'm in industry, so my job will not get lost likely. But the second thinking was, is this really true now? Is it really coming? For a couple of years, we've said, okay, we start seeing that AI is actually starting to gain traction. We started seeing studies like this already 2 years ago, where patients, when they were confronted with a chatbot, and they would not know whether they're talking to a chatbot or to a physician, would actually say, well, I really liked when this person talked to me, and I really felt I had more empathy there, that both quality and empathy were higher on the chatbot side. Let that sink in for a while. I'm a physician. When you read this, what do you think? We always said the differentiator for a physician is the human-patient interaction, and here we are. Technology is doing it kind of better than us, and this in 2023. So that was the first thing, which started challenging the thought that are we really not replaceable in healthcare as physicians? I was still believing that, well, in reality, real world is different than in studies. So when you're really exposed to the environment, patients really tell you, thank you very much, doctor, that you were here. I was 2 weeks ago in Tel Aviv in a hospital that is one of the best smart hospitals, 2026 Sheba Medical Center. And we walked through this department here that looks like a hotel spa, looks like a sauna even. This is actually the emergency room, a test environment, where the patients, before they even touch any other person, are individually brought into the room, and the chatbot is actually talking to them first. It's an AI-first approach, where the first triaging is done with AI chatbots. Now you will say, hey, here we will realize that people will actually say, I rather want to talk to a nurse or a doctor first. The statement here, and that's why it's here in quotation marks, was patients across different diseases prefer LLM-directed interviews over nurse-physician in ERs. That means, even in real-world empirical environments, now patients are telling us, get out of our way. And why do they tell us? So we asked, it's surprising that this message comes there, and they said, well, just guess what? If you're in an acute situation, you need to display a lot of your insights, so you need to share a lot of your personal stuff. And people gave the feedback, we know this is technology, but for the first time, somebody had more time to ask more questions, so they valued the time that AI can bring to the conversation. And the second thing was we're actually more comfortable sharing our personal, private stuff to a machine rather than to a human being. So it lowers the barrier in the interaction. I just want you to really think about this, beyond all the studies and whatnot, to think really from a person perspective what it means to interact with these things. You've seen the negative end of it, suicide and all these things, but there is a positive thing in it as well, which is where we are responsible, I think, and here the Dathaton team, etc., to bring those technologies in a value-adding fashion into the clinical environment. And why is this more important than ever? Because the reality around us, as it has been shared, is not easy. Not just because of wars. Even before that, we had a very, very bad situation in healthcare, as you see, with all the challenges that we have, and those challenges are mounting. They're not going away. They're just increasing every year. But we have now technology in place or in the starting field where we need to see, can we actually match them towards our challenges and see how we can leverage them. That's why we have the responsibility to think positive as well, to see like, how can we do this? To the point that was made, how do we make sure that AI is worth it? I don't want to double down too much on the challenges. It's widely known, but to just remember those challenges from a practical perspective, 90% of our cost goes to chronic disease management. This is US data, but it's in many, many older societies the same. One of the much more, let's say, important KPIs right now in the environment is staff shortage. Of course, AI will do the trick there as well, that probably people will lose their jobs, but in healthcare we have a different problem. We don't have people in the first place even to deliver care. So here, AI will not take away jobs, it will create jobs that we didn't even have in the first place. Think of the ER situation. If you have for the triaging process in an ER, no person for 1 hour, in some markets or some geographies for 6 hours. Think UK public healthcare systems where people wait in the ER 7, 8 hours until they have a first touch point. In those markets, AI may create roles that might even create more value. And we need to think of that combination, let's say, of value and opportunity. There's another trend, personalized healthcare, probably for more those markets where there is the opportunity to have access to, let's say, more advanced drugs and treatments. How do you make sure that the staff that you have, your clinicians that are overburdened with cognitive burden, how do you support them to actually make the right choices so that you can really give the right treatment to the right patient? Again, an opportunity, not a challenge that technology might solve. And why is that in personalized healthcare, for instance? Well, you know that, and we're guilty, in quotation marks in that regard, as a company, we're producing billions of data points per year just with diagnostic tests. We're producing sequencing results. That means the DNA that was mentioned this morning. There are also millions of and billions of data points. And in cases like a human being, it's even in an individual. We're creating millions of data points. And you know how many data points we can process as physicians as well? Let's add one additional data point because physicians may need to do this every day. Instead of 7, it may be 8 data points that you can handle to manage. When you start thinking of hundreds, if not thousands of data points to make a treatment decision, not doable. So that's really a big challenge where technology already has started to create value by bringing data together, processing and presenting it in a way that you can make better decisions. But AI is now starting to help us leapfrogging because we cannot contextualize the data, even if it's presented in the right way to us. We need to process it, let it be processed by AI. The numbers here about AI ML-enabled devices are actually showing us there's a longer history. It goes back to 2015, and the reason is AI is not just a recent thing for medtech. It started, as many of you will know, in radiology, because on the image level, it was pretty clear that what a radiologist sees with his or her eyes is probably not everything on the image. So when you started actually matching endpoints, and that's for the datathon, I think the thinking as well that we may need to bring into front and center here. If you think of endpoints and then bring all the data that you had on the imaging side into correlation and then let basically deep learning run over it, you start seeing that there's much more in the imaging data than you believed in the first place. And if you, even as a radiologist, then look at the image, you will not see those data points because they're just numerical relationships between pixels or voxels. But the thing is, there is a relationship that's hidden in the data, and I think tomorrow you're going to actually do that magic now outside of radiology and try to understand where is this relationship between different data points that might indicate a connectivity towards an endpoint. And mind you, I'm not saying causal relationship. Many people believe because there's no causal relationship, all these things actually don't matter. Well, they do matter because as a physician, I'm not doing something different. I learned the hard way over years basically how to create a connectivity between certain diagnostic test results and an endpoint, and these systems are doing the same thing at scale. You heard already about our internal processes. How do we actually deal with AI? Of course, with the entrance of LLMs, we got a booster, if you want. So we started seeing that we need to actually accelerate our efforts to, in a widespread fashion, implement these tools in practice. It starts with us. Before starting to preach using these things in clinical practice, we need to make sure that we are managing them, that we understand the shortcomings, but also the benefits of those tools. So therefore, there are different levels of programs within the company. It starts really with everyday AI. That means similar to what you do every day in your private life. We said in our professional environment, we need to make sure that we immediately bring these tools for learning purposes to crowdsource basically also the feedback and optimize them over time into our regular practice. So these are things like ChatGPTs, but also other tools that slowly change the way how we basically build products or deliver our services. But we also have larger projects where we look into really more larger transformational changes that can impact basically perhaps your cost base, but also your value base that you create for the patients. And then there might be bigger ideas that are really transformational. And these are things that you may know already on the pharmaceutical side, where we try to understand how can you, for instance, take AlphaFold and then with that actually accelerate drug discovery. But when it comes to the customer side, so our users, our clinicians, we started building as a digital health organization. By the way, perhaps I should spend one sentence on who we are. So I'm speaking not on behalf of pharmaceuticals, not on behalf of the diagnostics organization mainly, but I'm speaking for both of the organizations. For all of our products that we bring out there, we have a third product category, which are digital health products. And we decided years ago that because of all these challenges that we see on the clinical side, we need to help our customers, our users basically, to make decisions more with digital tools. So we started with clinical decision support tools that help the customers to bring data together, to contextualize it. And with the advent of AI, now we're actually getting into the next stage. So how do we basically bring AI into our product landscape? You will, when you go outside, you will see there's a brand called Navify. That is under that tag, basically, we bring our digital health tools together. But the integration of AI happens in three distinct categories of value creation. One is, I think, very obvious, predict. That's the theme for your data from tomorrow, I think, as well. So how do we create value, basically, by implementing AI models in clinical practice to make sure that we can detect diseases earlier? And it's not this classical only screening type of approach where you try to really capture, let's say, breast cancer at an early stage with the same diagnostic tools that you would use in routine. No, this is about identifying disease at a much earlier state because you do apply a different way of trying to finding it. So that is the algorithmic approach, basically, that we're trying to implement there, and you will see some examples there. Second is perform. Healthcare is not just about the clinical content, it's also a lot about operations. The cost in healthcare is not just the drugs or the tests or the physician's cost, it's the cost that is basically generated by the operations in healthcare. And as you know, in healthcare, at least in the US, we say we have $1 trillion of cost that needs to get out. Some part of it we can actually take out if we can perform better. So that means the clinical workflow optimization comes into scene. And last but not least, there's personalization, as I mentioned before, where it comes from. How do we make sure that clinicians, but more so now also patients, get to the benefit of using AI models in their daily life? This one is a little bit overloaded slide, but I wanted to show you one system level approach, and systems thinking or system biology or systems medicine is one of the takeaways perhaps that I want to drop here as well, similar to the first speaker, to really keep in mind also when you think of the Deathathon tomorrow, not to think in isolation about a use case, but really open your aperture towards the bigger system. So when we think of implementing AI in clinical practice, or even our digital tools, we always think about these three categories of things that we can influence. We are a big diagnostics company, the biggest diagnostics company. We have billions of data points that come from the lab, and the lab is increasingly basically connected to the rest of healthcare. So one thing is, how do we make sure that data that comes from IVD, so in vitro diagnostics, from sequencing, from pathology, from mass spec, how do we bring those data together? But not only those, how do we contextualize this with the rest of the data that we have? Electronic health record data or wearable data, etc. So the connected lab piece is one. Then we have two entities, two people, two categories. There is the clinician that needs to be able to identify the right test at the right time or identify the right treatment at the right time. they will be the ones that will use basically all those algorithms. So how do we make sure that the clinicians get the right type of test, digital test that is as well, at the point of decision making? And then you have the patient. And the patient is a moving target, quote unquote. They were in the hospital in the past, and in the US market mainly right now, there's a big trend towards care at home. So people get basically discharged out of the hospital at day 1 after surgery, or they get their treatment in the first place in the home setting. So hospitals are struggling right now to find good ways how to remain in connection with their patients. But it's not just a technical connectivity. Just guess you have a, let's say, a bone marrow transplant patient, very critical procedure, and you bring them to the home setting right after the transplantation. There are a lot of data that you need to create on the patient side, bring it to the care team in the hospital that makes then decisions on whether the patient needs antibiotics or other types of things. So there is connectivity necessary, but there's also a new wealth of data that the patients are producing with sensors and variables that need to be brought into the care environment. So that's the third piece. All these things will trigger one thing, which is interoperability. Many of you will know. So in order to create not only the right data, but to bring them into algorithms, we need to make sure that the data is interoperable in the first place. So therefore, as a company, we decided to invest also into the infrastructure. So to make sure that data flows from the different data domains into the algorithm environment so that the algorithmic process can even be done in the first place. So a couple of examples as to where do we really have then these AI models today. On the predict side, one example is sepsis. The other one is LGI flag, 2 different disease categories. What do we try to do? Sepsis is one of the most important killers in the hospital environment. 11 million patients a year die with sepsis, a disease that oftentimes even originates in the hospital. So it's not that the patient necessarily comes with sepsis into the hospital. So there's a lot of attempts to earlier detect the patients in this acute disease state. Hours count. So if you're able to detect the disease a few hours before the onset, that will give you a higher likelihood of survival. So for that purpose, there are algorithms that basically track and trace all the different parameters. Is it vital parameters, lab parameters, and contextualize them based on trained algorithms and give you a result that gives you a flagging possibility that a certain patient in the hospital might develop sepsis in the next couple of hours. This is one of those older areas even where algorithms were developed in practice, and it was a learning period as well. So biases and other types of influences actually brought us the first phase of AI winter in healthcare, if you want, where people said, nah, these algorithms don't work. There's a lot of bias in the training data. So this is already, if you want, second or third generation, and this is the one that is also the first FDA-approved algorithm. So we have an open innovation ecosystem where we bring these algorithms from external companies on our algorithm suite platform. So that's one category. And the nice thing is we focus on laboratory-heavy algorithms. So I'm not sure tomorrow when you deal with the data whether there will be a lot of diagnostics data as well. But for us, it's important that we can control the risks and understand truly how the algorithms work to the part of explainability and transparency. So we basically look into algorithms that are, again, lab-heavy. Second one, also lab-heavy, is Navify LGI flag. LGI flag means low gastrointestinal flag. It is an algorithm that is very simple. And with simplicity, I mean it just takes complete blood count, age, and gender. Also for your datathon tomorrow, it might be interesting to bring in sometimes the curiosity to see how can I basically also with a simple extension of my data set suddenly unlock more predictive power. And this is one of those algorithms that allows us with very simple blood tests that every patient gets, and with the EHR information on age and gender, to identify 8 times higher the possibility that a person has a lower gastrointestinal pathology that might be indicative of cancer. Why do we need such a test? Well, you know that colonoscopy screening is not widely implemented. Oh, let's say it this way, people don't go and take it. So if you can do this test, which doesn't cost a burden for the person, do this beforehand and then can tell, well, you know what, you have an 8 times higher risk to have the disease, then people are much easier ready to undergo colonoscopy We have been proving this in the United States, so we believe these type of tests will become mainstay, table stake in even private practice. On the operational part, quickly, operational can be meaning many things. We have operations on the lab side, so our IVD laboratory, sequencing, name it, all these, or pathology, all these people there have operational workflows where your tools can support, and they are getting more and more enriched with AI. On the clinical side, it might mean how do you accelerate, for instance, the process that a person takes in order to, for instance, create results for a patient. So the first example here is something that we call Clinical Hub, into which we have implemented or integrated an LLM, basically summarization tool. It's a very simple approach, and simplicity is here king. Why? Because we can manage the risk. We're not giving the chatbot to the customer, we're basically giving them a summarization that we have pre-validated, and we give the customer also the possibility to manage or edit the summary that is there, so there's still some human control. I don't want to call it human in the loop, but a human control aspect. But what is the benefit of this? Just imagine if there's a cancer patient that needs to be discussed in a multidisciplinary team meeting, it can take up to an hour to prepare such a case. Oftentimes, the oncologist would give it to the resident in charge to actually bring all the data files together, create the case, sometimes a PowerPoint even, pull the imaging data and whatnot. Here is an approach that actually crawls through the data and summarizes the case. Doesn't take even, it takes a few seconds, let's say it that way, not even a minute. And you have the case summary ready for discussion. It saves time, and that's the operational aspect. So sometimes that time saving can result in very significant impact. In the US market we have, and likewise in other markets, staff that's exhausted. Clinicians are exhausted, care personnel is exhausted. If you can free up time for the people operationally, that's a big deal. On the lab side, same thing. Operations in labs are important. Why? Because labs are getting bigger and bigger through economies of scale. The routine is getting bigger. But so far, the operations management was typically supply chain management, making sure that the process flows, but that was it. But the interaction with the data itself was pretty rigid. So you had your KPIs that you could monitor, but you could not talk to your data. That's something that we use now as a terminology when we say, hey, can we integrate an LLM solution in a way that allows you to interact with your operational data? So if you as the service line manager interested to truly understand your workflow, your performance in your lab, your issues in the lab, you can actually more freely interact with your data instead of having basically tables that come with very fixed results. You can interact. So this is an upcoming tool that we have. We call it Intelligent Lab because you can now interact with your lab in an intelligent fashion. This tool understands what you really want and helps you to improve your operations. And if you go one step further, you can say you can start actually making predictive performance assessments. So if you have a lab that has been in operation for years, you have plenty of data, what seasonality means, what type of performance issues you might have, what type of staffing issues you've had in the past. Wouldn't that be nice if you can actually use all of that historical data to now make better predictions about the next hour, the next day, the next week, and optimize your staffing, your inventory, all of that basically based on these predictive things. Now, as I described this, you will realize this is not big AI, but it is so much of value because you can translate it immediately into practical implications. For us, that means the risk of AI is low, but the benefit at this point already pretty high. Pathology is another field where, because it comes from imaging already, AI was already in there for quite some time. What is happening right now is pathology images are being analyzed also by a lot of small startups, and I think there might be even here in the room some people who deal with imaging data. Why is it important in pathology, particularly compared to radiology? Well, there are still a lot of radiologists, but there are not so many pathologists anymore. That's one thing. So you need to make sure that the remaining pathologists that are interested actually have enough tools to manage the workload. So it's going to become increasingly a very throughput-oriented environment. And as such, you want to also start automating more. So the big driver is staff shortage and automation because of that. But then when you add what I said to radiology, that you can start seeing things that a human cannot see, there's an additional piece on diagnostic accuracy. So you can start detecting things easier, better earlier, and you might even predict things that are not pathology insights per se. What I mean with that is there are now first pathological models that can predict basically your mutation profile, tumor mutation profile, without doing a genomic assessment. So it will change the way how we basically even have a workup for our cancer patients, because the pathologist suddenly will be able to create more insights and change the way also of the further testing that comes with it. Last piece, personalization. Well, this is an important one. I already shared with you that hospitals are highly interested in keeping connectivity to the patients, but even when the tools are in the patient's hands, which is in this case in diabetes care, there are a lot of opportunities how you can make a big impact on patient care. I'm not sure whether there are any diabetic patients here in the room, but speaking on behalf of those, we have a lot of those people working for us. We are very inclusive in that regard as well, to make sure whatever we built there actually has truly an impact. And one thing that we have implemented in our applications is right now that we have a warning, a prediction approach to hypoglycemic events. Normally, it's a symptom-based approach, right? And then you start making your measurements for glucose to see like whether your glucose level is going down too much, where you need to intervene. And it becomes pretty dangerous if it happens while you sleep. So there are not rare situations where then due to a hypoglycemic event, suddenly a person doesn't wake up. And it is important, therefore, to have prediction for the night, for the next 7 hours. That's what these algorithms now give. Patients can actually, based on their own profile of how their glucose level typically behaves, predict whether something like that could happen in the next couple of hours. And the intervention is pretty simple, to take a bar of Snickers or whatever to keep their sugar level high. So, pathology, we have said, so for time reasons, I would basically come to my last slide. Why partnering with us is important. As we said, this is a great environment to actually highlight that as well. Not only that we're incorporating AI now in all of our development activities, what is really true is this is an ecosystem approach. No single company can actually innovate in this environment enough, A. B, we need to get data and insights from all geographies because of the diversity we need to mitigate the risks that you have heard all along this morning. And C, this is an economy that will evolve. On one side, we say it will take hundreds of millions of jobs away, but think of how many people are here in the room just because of AI. This is the future. So the quicker we actually adapt our skills to the necessities and opportunities that AI brings us, I think the better we will be prepared as societies to actually create new value creation environments with AI. Therefore, net, I'm still positive about the opportunity, so I would not run away out of this room today and think, okay, it's going to be doomsday, but rather make sure that we actually leave our mark in healthcare, because healthcare needs you. Thank you very much.